Welcome to Healthy Minds for Working Men. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all these items when they're available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Jianli Wang. Jianli Wang is a professor at the School of Epidemiology and Public Health, Faculty of Medicine, University of Ottawa. He holds the position of Senior Scientist and Director of Work and Mental Health Research Unit of the Institute of Mental Health Research affiliated with the University of Ottawa. Prior to joining University of Ottawa in 2017, he was professor of the Departments of Psychiatry and Community Health Sciences at the University of Calgary. Dr. Wang received his PhD in epidemiology at the University of Calgary. And now I'll hand it over to Dr. Wang.
Great. Well, thank you very much, Angie, for the introduction. And good afternoon, everyone. And for those who are in the West, good morning. Thank you for having me here. My name is Jianli Wang, and I'm associated with the University of Ottawa and also the Royal Institute of Mental Health Research. Just a few words about this research institute. The Institute of Mental Health Research, or IMHR, is a research entity of the Royal Ottawa Healthcare Group and is also affiliated with the University of Ottawa. The Work and the Mental Health Research Unit, for which I'm the director, is one of the 6 research units of the IMHR. We're dedicated for better workplace mental health and better productivity. So this is our goal, and we seek to achieve this goal by producing scientific knowledge by our members' own research, and also pulling research evidence from different sources to facilitate interdisciplinary dialogue and cross-sectoral dialogue, just like what we're doing today. So this is just a few words about the MHR and our research unit. All right, to begin, I would like to show you a few pictures and to see if you could recognize the faces. So here we have 2 pictures. I think most of you could recognize these 2 faces. On the left is Jim Carrey, who is the Canadian actor and comedian. And on the right side is Robin Williams, the American actor and comedian. And let's look at the next 2. I'm not sure if you can recognize these individual on the left side, and the man on the left side his name is Romeo Dallaire. He was a Canadian military general and now is a senator of Canada. On the right side is, as you may tell, is Winston Churchill, the former British Prime Minister. Okay. So these are the high-profile people from different countries and different fields. But they have something in common. They are all strong men, and they all had the experience of major depressive disorder. And as you know, Robin Williams died because of that. So the message here is, no matter who you are, and where you are, your social status, you are not immune to depression. Depression is what we're going to talk about today. There are many different type of mental health issues in workplaces, but apparently depression is one of the most prevalent and disabling one. So today's our conversation will focus on depression. Today I'm gonna address three questions. First one is, what is major depression? Everyone here knows, maybe familiar with the term depression, but let's compare our notes to see if the depression I'm talking about is the same as yours. And the next one, we're going to talk about what is BroMatter. BroMatter projects is one of the ongoing projects we're doing at our research unit. And we're also going to talk about who are involved in the BroMatter projects. So what is a major depression? Well, to make a diagnosis of depression, clinician needs to use a set of criteria. The criteria used in North America is called Diagnostic and Statistical Manual for Mental Disorders, or DSM. The DSM outlines 9 depressive symptoms, and the first one you can see from the slide is depressed mood. People say, I feel blue, I feel down or sad, which is the same thing. In children, youth, and some adults, depressive mood may also manifest as irritable mood or anger. And in some cases, people with a depression say, I feel nothing, I just numb, just feel numb. And the second one is a loss of interest in activity. Some employees used to enjoy like hockey or group activity, the team work, but suddenly, they lost their interest. And some used to usually enjoy talking to people, and you can clearly observe that these individuals suddenly isolated themselves from the group. And this sudden behavioral change can be a sign of depressive symptoms. Number 3 is change appetite and weight. Some of us may have the experience, when you feel under stress or you feel stressed, what do? Some eat, eat chocolate, chips, anything to alleviate the stress. But the consequence is you gain weight very fast in a very short time period. Sometimes for people with the depression, she or he can gain about 5% of his or her body weight within a short time period. But on the other hand, some people have no appetite at all, don't want to eat. So number 4 is insomnia or hypersomnia, which means you have difficulties to fall into sleep or wake up very easily. And once you wake up, you have a problem to go back to sleep. So we all know what happened if you couldn't have a good sleep. You cannot do anything the next day. Another group of people on the other end of the problem, they sleep too much, called hypersomnia, but the quality is not good. So as part of our research in the BroMatter, we developed an online program to help men to deal with the stress. And we first conducted a national survey in men and asking them, say, if we want to design a web-based program, what kind of feature you want us to include? And on the very top of the list, they said they want something that could help them to have quality sleep. Okay. Number 5 symptoms is the psychomotor agitation and retardation, which means they cannot sit still, they can move back and forth, or being physically slowed down. And these changes are clearly visible for people who are living or working with this person. Number 6 is fatigue and the loss of energy. Many people with a depression have difficulties of getting out of bed or looking after themselves. And you may wonder why they lay in bed all day, just why not just get off the bed and do something? It's not because they don't want to, but they cannot. They just don't have the energy. The number 7 symptoms is feeling guilty or worthless. They always blame themselves for any bad things happen. They always think themselves as not good enough. Over the summer last year, I met my friend's daughter, who's 25 years old, well-speaking, very talented artist. And she likes to help navigate, when my friends drive, when they're on a family tour trip. And every time if they missed a turn, and she would have tears in her eyes and blame herself not being, for being useless. And even the parents comfort her, say, okay, it's okay to miss turn. And, but she still, constantly blame herself. She has been on antidepressant for over 10 years. Number 8 is difficulties in thinking, concentration, and making decisions. So this is why depression can have a huge impact on job performance and productivity. Unlike the employees who have a flu or had surgery, they can, be off work. Many people with depression, they go to work, they come to work, but sitting in front of a computer and but cannot do anything because they cannot concentrate or can only concentrate for a short period of time. So we call, as you may be familiar with the term, it's called presenteeism. The last symptoms is suicidal behavior, having thoughts about killing themselves, making specific plan, and even attempted suicide. So one of the severe consequences of having depression is suicide. So whenever a suicide occurs, it's tragic and has long-lasting impact on family, friends, and also it's not good for corporate image. Okay. So if once in a while we all have one or some of these symptoms, does that mean we have a clinical depression? The answer is no. Because if you, for one, to make the diagnosis of major depression, you have to have at least 5 of these 9 symptoms, and one of them should be either depressed mood or loss of interest. And also these symptoms should reach certain level of frequency and intensity. So these symptoms you should have all these symptoms coexist for at least 2 weeks, most of the day, and nearly every day. And the third dimension for making a diagnosis is all these symptoms should have an impact on your functioning. The symptoms should have affected your interpersonal or occupational or the social relationship in a big way. So many people may have depressive symptoms. Only a proportion of them could reach the level of major depression, or we call it clinical depression, according to this DSM criteria. So I'm not sure how many of you are from Canada or from the other country. So based on the criteria we just described, you may have, for those who are in Canada, I'm asking you to think about it like how common major depression would be in the Canadian general population. So you may have a number in your head now. According to this diagnostic criteria, based on the data from the most recent Canadian National Mental Health Survey, the annual prevalence of major depression in a Canadian adult is 5%, which means out of 100 adults, 5 of them will experience a major depressive episode in any given year. That will translate it into over 1.3 million Canadians aged 15 and above will have the major depressive episode based on the criteria we just described. Women are more likely to have major depression than men. So in Canada, the annual prevalence for women is 5.8%, for men is 3.6%. So women are more likely to have depression than men. So people will say, okay, so because the prevalence of depression in women is higher than that in men, the prevention effort should focus on women. That makes sense, but it really does not make sense because it's also prevalent in men as well. And on the other hand, even though women are more likely to have depression than men, but men are more likely to die because of depression. And over the past 10 to 20 years, based on Statistical Canada data, over 75% of suicides in Canada are males. And also the depression have a huge, considerable functional impact on your relationship and on the productivity. So depression is a such complicated issue, especially in workplace. So how are we gonna deal with that? There are many ways to deal with depression or any mental health issues. The traditional approach is, as we know, is wait. Wait until things getting really, really bad. And then at that point, you go to see your doctor, you go to see your psychiatrist, and the health professional prescribe you antidepressants or the cognitive behavioral therapy, with the counselor or psychologist or the CBT, right? But interesting thing is, we look at the population data in Canada since 1994 until now. We observed a significant increase in mental health services use in the Canadian population. We observed a significant increase in antidepressant use in the Canadian population, but we have not seen a measurable change in the prevalence of major depression at the population level. And this is not unique in Canada. We observed the same thing. Our colleague published similar results based on data in the United States, the data in Australia, and also in Europe. So it's not a unique phenomena. It's kind of like a cross-country, cross-culture. There could be many explanations about why we haven't seen a reduction in the disease burden. For example, one of the explanations is people have not enough people to use the mental health services, or even among those who use mental health services, the quality of care they received may not be optimal. But some researchers in Australia, they used an economic model and shows that even in the ideal world, everyone with a mental health issue receive mental health services, receive the mental health services at the best quality of care as we can provide. Even in that ideal world, everyone received the mental health services, but that can only reduce about 40 to 50% of the whole disease burden. So it's quite puzzling. And so some of the researchers and the policy makers think, well, we have been focusing our efforts on providing services, providing treatment. We have not done enough in prevention. We have not done invest sufficient amount of resources in early prevention. So this is what our program trying to do. We're trying to identify solutions that we could use to intervene before the symptoms could progress into a full-blown of major depressive episode. And we know depression is not, there's no clear cut between depression and non-depression. And depression is on the spectrum, ranging from healthy to the other end of clinical depression. And there are some people in the reacting stage show some early sign of having depression or the early sign of risk. Some of them will progress into clinical depression, but most of them will not have clinical depression. So our program, our research, especially for the BroMatters, we're trying to identify the individual at the reacting stage who are at high risk of become clinically depressed, and then to provide the intervention at the reacting stage so we can stop depression before it happens. Okay? So this is what the BroMatters is about. And for BroMatters, we will develop two products. And one is an e-mental health program. And this e-mental health, for those who are not familiar with the e-health program, is mental health services or any health services delivered through the internet, through computer or by mobile phone or other information technology. We're trying to develop an e-mental health program to be used by working men who don't have major depression, but are at high risk. So we're going to explain how we're going to define high risk later on. So we will develop this program and to be used by this high risk group. The second product we are going to develop is an open access education resources. We're going to combine the workplace challenges and the issues that frequently encountered by men in the workplace that make them feel stressed, and also we can identify evidence-based solutions. So in the future, we're going to combine both challenges and evidence-based solutions in one package. So, and put it in the open access area, anyone can use it to make a reference. So these are the two products we're going to develop through the BroMatters. To develop the e-mental health program, the BroMatters in total has three projects. The first one is a national survey in the high-risk working men about their preferred design features of e-health program. So we're trying to understand, okay, if we develop a e-mental health program, will men at risk, will they use it, such a program? And if they want to use it, and what are the design features they would like to use, they want to include in this e-mental health program, and what are the barriers for using such a mental health program. So first, we're going to talk about how we define or determine high risk. Many of you say, okay, I know who are at high risk. Women, because you just said women are more likely to have depression, or individual with family history are at high risk, or young people are a high risk population, which is true. But here we're talking about a relative risk. For women are at high risk, you're compared with men. Individual with family history, you're comparing with those without a family history. So you're comparing to the other. So that's a relative risk. The relative risk is very useful in epidemiological research in terms of identify specific risk factor. But relative risk has nothing to do with the individual. So many of you today here, maybe some of you may be a woman, or maybe you have a family history of having depression in your sibling or your parents, but that does not mean you as an individual will be at high risk of having depression, because the relative risk does not put an individual in a specific context. Okay, so I show you another example, which show about an individual. It's talking about absolute risk. Here we're talking about a man, John, who's 30 years old, does not have a major depressive episode, and his brother had depression before. But John had the childhood experience of physical abuse and parental divorce, but currently John has some problem with the sleep. Okay, so now we put a person in the context. So the next question we would ask naturally is, what is John's probability of having depression in the next year or in the next month? So here we're talking about absolute risk, which is more relevant to this individual. And such absolute risk can be estimated by a multivariable risk prediction model. We have developed such a risk prediction model, one model for men and one model for women. We used the data from over 10,000 Canadians, men and women, been followed for 8 years. We developed the two risk calculator. The models for men and a woman have some overlap. For example, like a family history. But they're also different in terms of the specific questions related to ongoing life events and also childhood trauma. So both models include personal characteristics, family history, life events, and traumatic events in the childhood. But the specific questions about life event and trauma are different for men and women. So we developed these two risk calculators for based on the large Canadian data, national data. Okay, it's not moving. Okay, for the Project A national survey, we used the risk calculator to identify the working men who don't have a major depression but are at high risk. And the survey was conducted in 2015. We interviewed 510 high-risk men and 330 low-risk men. First, we asked them the question about their internet use for health information. Here are some of the results, and we can see for the high-risk men, working men, a majority of them in the past 12 months used the internet for something. And over 83% of them used the internet through the mobile device. And the same percentage acknowledged the importance of accessing health resources or information through the internet. So a majority of the men, no matter they tell you or not, they've been using the internet searching for health-related information. Before the survey, we had some hypotheses about what kind of a design feature they would like to use. For example, the cognitive behavioral therapy, CBT, or the mindfulness relaxation. We know they probably going to need this kind of a feature, or also the information about workplace depression, risk factors, and the early signs, etc. I mentioned early that which was quite surprising. You can see here on the left column is the design features we asked, and which is we arranged this in a descending order in terms of the proportion of people who endorsed these design features. So in the middle column, under highest risk, are the number of individuals that, well, I would like to use this feature, and in a bracket, that's the proportion of people who endorsed this design feature. And you can see from here on the very top is the design feature is the information about improving sleep hygiene, something about sleep. And on the second is practice and exercise to reduce stress, which is mainly the CBT, cognitive behavioral therapy. And number 3 is quality information about work stress. And number 4 is a setting goal, personal goals, and how to track them. Number 5 is watching videos online on how to deal with work and stress issues. Number 6 is being able to access a program via smartphone or as an app. Okay, so these are the top 6, and this page shows the bottom 4, which is quite surprising that we know that some of the peer support group or the online chat forum have been very successful, have been promoted by different organizations. But when we ask about the design feature, say, would you like a kind of like online chat room to be included in this eHealth program? And actually, the preference for these two design features are on the bottom of the list. One is 27%, one is 25%. And we asked them, say, if we design an eHealth program, would you or would your like a male, female colleague, would you use such a program to deal with work-related stress? 72.6% of this men said yes or maybe we will use such a program to deal with the work-related stress. There are a number of barriers for using eHealth program for mental health issues. The first one is, here are some of the examples. One of them is, of course, as you can imagine, is stigma and confidentiality. Over and over, especially for men, they, quite very often they ask, what is somebody else gonna see I'm using this program? Or how the data I provided can be used. So they are very concerned about confidentiality and perceived stigma. The other barriers they perceive is the eHealth program maybe lack of a personal interaction. Some of them say, well, I prefer to talk with a real health professional about my issues. The other barriers is a lack of time. I don't have the time to use this eHealth program, especially for those who work in office setting. They've been using the computer for a whole day. The last thing they want to touch after work is a computer. And another barrier is a lack of knowledge, saying, I don't know what an eHealth program looks like. I have no idea at all about how that, whether or not I'm going to use. Lack of knowledge is a barrier for use, but it does not mean that they will not use it when you have the products in their hand. And sometimes for new products, if you put the new product in their hand, they may say, wow, this is cool, I'm going to try it. So lack of knowledge may be a barrier, but may not necessarily impact the potential use in the future. So this is project number 1. Okay, so we have published all these results in a peer-reviewed journal called the Journal of Medical Internet Research. If you want a detailed information, you can always contact me about this paper. So this is about the national survey. So next project is, the second project is we conduct a randomized control trial to evaluate the effectiveness of this eHealth program in reducing the risk and in improving productivity, and to evaluate to determine how many depression cases may be prevented and what is the return on investment. So this is an ongoing national randomized control trial. And here is a snapshot of the web-based program. We have 4 modules there. One is quality information about stress, depression in workplace. Second one is the evidence-based strategy for reducing stress, which include the CBT and other strategies. And the third module is the tool they can use to monitor their symptoms and depression, and also to conduct a self-assessment for not only the current depressive symptoms, but also for their future risk. And the number 4 is the smart goal setting and tracking. So they can set up their personal goal and also to track the progress of their work. And within the self-help module, we include the CBT, mindfulness relaxation, and also specific strategies for dealing with the work-related issues, such as how you could communicate with your colleague and the supervisor about mental health issues, and also work performance issues, etc. The unique feature of this eHealth program is based on the CBT, which is a proven therapy for depression and anxiety. It's also a focus for work-related issue. We also have a balance of text, video, and pictures in the program. It's in a modular format, so they can go to any module they want based on their needs, rather than through a linear format, like say you have to complete this questionnaire before you can move on to the next one. We have both English and French version. So for the national trial, we have our target sample size is 1,200. We plan to randomize them into 3 groups. One is control group. One group going to receive this web-based program. The other group, the third arm, going to receive the online-based program plus job coaching services through the telephone. Now we have completed the baseline interview, recruitment, randomization. We have just completed the 6-month interview, and now we're working on the 12-month follow-up interview. We have recruited and been following 1,100 men across the country. The third project of the BroMatters is to develop this open access education package. We have conducted a cross-country qualitative interview with over 250 men in the workplace from a diverse industrial sectors, and we have put special attention in the sector of the male-dominated sectors like oil and gas and construction. So we're through this focus group or qualitative interview, we're trying to understand, say, what are the workplace challenges that make you or your coworkers stressed? How you deal with it? Is it effective? And what can your employer do to help? And we have identified a number of workplace challenges that men feel make them stressed. And here I show you one example. One of the common workplace challenge for men is work stress, of course, and the job demand, the heavy workload, very tight deadline, and very fast work pace, especially under the current economic situation, with the co-workers being laid off, and the people who have to still do this, to complete all the work with limited resources, with the less human resources. So job demand is one of the frequent workplace challenge or stressor mentioned in the qualitative interview. The other challenge related to the work stress is support. Lack of sufficient support from supervisor or from co-worker. The third one is work-life balance, how the work could interfere their family responsibility, because the company organization, so frequently put them on travel. They don't have sufficient time to spend with their family, to deal with some of the family issue, especially when they also have the caregiver responsibility, taking care of the the parents and small children, etc. The other thing related to the work stress or the work environment is the uncertainty, especially in the western part of the country. Uh, the job was hit very hard by the economic crisis, and many people are being laid off and or see their colleagues being laid off. So they started to become anxious and worry about their own job security and how that may affect their family. Like say, if they have children, small children to support, children who are in the universities to support, if their position is not secure, how are they going to do if the layoff happens to them? So it's quite a anxious and stressful story out there. What they do to deal with the stress. Here is just some of the examples they use to deal with their stress. Physical activity is one of the commonly used strategy to deal with the stress. Say after work, I just go to the gym, do whatever, or the eating healthy diet, sleep more, don't drink. Some of them, quite often, they seek social support, but they seek support from the people who they trust, like their spouse, their family member, or friends. Some of them use their online chat room, but it's in an anonymous way, talking to people have similar experience, but they don't know each other in person. Or they develop their own hobbies or projects like reading and do hockey or whatever. These are also reading, or even just sitting in front of TV, mindless, just to get their attention after work. They think anything they do that are not related to work help their mental status. So those are the strategies they use by themselves, and also access the work resources, like talking to co-workers. Some also actually talk to their supervisor about the personal issues, and some of the organizations are very supportive and accommodate their needs. So here is a case vignette we summarized from the interview. So we're gonna, as a next step, we're gonna summarize some unique case vignette and develop the questionnaire to describe just the person's context and the workplace challenge he encountered. And then we're gonna do a Delphi study to organize expert panel to let the expert to reach the consensus about what this individual could do based on research evidence or based on their practice. Say, for example, this individual, John, like 39 years old, with one child with one daughter, and he has the work-related stressors, including the unexpected travel, disturbing work-life balance, not being able to take a vacation, increasing goal and the targets that must be met, and also they have the family, children to take care of, and the parents to take care of, and so as for such situation, what John could do, what the research evidence show, what is the best practice for dealing with such complex issues. So next step is we're going to organize expert panel to reach consensus about the solution. So first of all, we're going to show the expert what the research evidence say, what the best solution would be, and then we're going to ask the expert to rank or rate whether or not they agree that this is an effective and important solution for such a situation. If we could not find research evidence, we're going to ask this expert to based on their personal experience, based on their practice, what would be the feasible or practical solution for John's situation. So we're going to organize 4 panels. One represent HR, employer, and executives, and second one represent service providers, like a health professional, consultant, and another group will represent people with a lived experience or from union perspective, and the fourth group will be the academic researchers. So I understand some of you, maybe from the HR perspective, or maybe from the employer perspective, if you would like to be involved in such expert panel for this initiative, and give me a shout by email. Here's my email. It's jenly.wang@theroyal.ca. So we're going to start it in the next couple of months, and by the time we're gonna start, I'm gonna let you know about the potential time commitment, and you could decide whether or not you want to do it. It's okay, and you can withdraw anytime you want. So if you're interested, send me an email. So who are involved? This is a truly interdisciplinary and multi-site collaboration. It started when I was at the University of Calgary. It involved a colleague from UBC, U Ottawa, Queen's, University of Montreal, and McGill. We also have a number of community partners like Mont Chapelle, Mental Health Commission of Canada, and Canadian Mental Health Association, etc. So it's not just by myself. It involved over 30 colleagues and collaborators across the country, and also some from the United States. We also, we have 3 projects, and we have a subcommittee for each project. We also have a stakeholder advisory committee for the whole project. And so this stakeholder advisory committee will not be involved in specific operation, rather than give us the direction about the research, future research, and help us to plan the knowledge translation. So the SAC committee has a representative of employer and service providers, unions, and the workers, and they're from different provinces, coast to coast. And now we comes to the conclusion. And I said at the beginning, I want to address the 3 questions. And the first one is, what is the major depression? What is BroMatters, and who are involved in BroMatters? So if we're talking about depression that meets clinical criteria, in Canada, 5% of Canadian adults will experience a major depressive episode each year. So it's prevalent. No matter who we are, where we are, how much money we have, none of us is immune to depression. And depression imposes a huge burden on employees, health, and economy. One of the severe consequences of having depression is a suicide. So, providing clinical services is absolutely important, but as a public health researchers, I would encourage you to think more on early prevention and think more on stopping it before it happens. Just like how we deal with the physical illness, we always emphasize on early prevention for physical illness. Benjamin Franklin once said, 1 ounce of prevention worth a pound of cure. So this statement is still true today, and particularly true for mental health problems. And BroMatters is an initiative focusing on early prevention using e-health approach, which has the advantages of accessibility, anonymity, and low cost. So we're also going to develop education material on workplace challenges and best evidence-based solutions. So employees may learn how others deal with workplace issues and the best practices. So our goal is to enhance employee resilience, so they have a better control over their lives and a better productivity. And as employers, at the end, you could have better, happy employees and productive employees. So I would like to acknowledge our supporter, founder, the Movember Foundation, to support the whole research program. And many of you know Movember Foundation is a global charity supporting men's health. So that's the end of my presentation, my talk. So now I welcome questions.
Thank you. And to our audience, if you have any questions, please enter them into the question and answer box on the GoToWebinar panel. Some questions that came in. Does your research and BroMatters apply to those with comorbidity, depression and anxiety, or depression and addictions?
Well, in the workplace, depression never exists alone. It's rarely to see pure depression. Depression always comorbid with anxiety and with physical illness. So our program focusing on depression, and by research we know depressions always have a bi-directional relationship between, with anxiety or with the physical illness. So by focusing on depression, we can also address the other mental health issues and physical issues.
Okay. Another question. When speaking about prevalence, is there any evidence that depression in men is underreported due to stigma or other factors and could be closer to the rates seen in women? If so, how would we encourage men to seek help such as what's been presented today?
Wow, that's a tough question. Well, I agree that depression in men is underreported because of the stigma and also the masculinity norm, because as a man, you always educated or raised, like say, you should be strong, don't show any weakness. And so you're grow up from that environment. And so depression can be underreported by men, and women are more likely to talking about this emotional issue. They're more open to they have more knowledge about the depression, because we a couple of years ago we did a provincial survey back in Alberta about depression literacy. We know that women knows more about the depression. They have a better depression literature. They have a less stigma against the depression. So from there, we could understand that men may be reluctant to talking about emotional issue, and they don't know actually to how to express their emotional issue. We talked to some of the men, and they struggle about this and say, I don't have the appropriate language to describe my feeling. Compared to women, there's just like they don't have these the terminology or word to describe their emotional issues. How to encourage them to seek help? That's really tough. We've been struggling with this question for a long time. As I just mentioned, because of this, we still have a tremendous amount of stigma against the mental health issues, and also because of the masculinity norm, men don't seek help until their condition become really bad. So that's the issue. And when we talk to our participants, they say, well, when I feel not that bad, I'm okay. I just deal with it by myself. And I may only seek help when my condition's getting really, really bad. I should not do that, but that's what men do. Right? So it's really tough to encourage them to to seek help, I think it gonna comes a long way in terms of education. It's gonna take a long time to educate and to promote the awareness, to raise the awareness about depression or mental health issues in men. So they can they can know more and more about these mental health issues and how that may affect their productivity and their personal life. And so think about the cancer, or the like 20 years ago, how much stigma attached to that. So now it's getting better, much better, in comparison to mental health problem. I think it's gonna take a long time for men to realize how important early prevention should be, and we should still work on not only to raise the awareness about mental health issues, but also reduce the stigma against the mental health issues, so they have an open environment to talk about mental health, and so they're create such an environment for them to seek help. I think that's still gonna take some time.
Mm-hmm. You mentioned some algorithms that you developed to predict depression. Are these algorithms available for use?
Yes, these algorithms have been published, and we also developed an online version. Now it's in the public domain. You can go to the website called predictingdepression.com. Okay, predicting depression is one word, .com, and you can access this risk calculator there. So these are for personal use, and you can use for self-assessment.
Okay, we'll include that website as well for our audience members following the webinar. Another question, when do you anticipate your open access resources will be available?
Now we are doing the literature review to summarize the best evidence for each workplace challenge, and then we're gonna work on the Delphi study with the expert panel. So we are hoping this study gonna be completed, or the package become available by the end of this year.
Great. I think that's all the questions we have for now. Dr. Wang, is there anything you would like to add following your presentation?
No, I just well, thank you for coming here and listening to this talk. And I just want to say that mental health problem in the workplace is such an important issues, and I do encourage you to think about not only providing treatments or clinical services, but also think a longer term for prevention, and so we can take a preventive action, and to so they, no matter the man or woman in the workplace, so they can have better control over their work life, their personal life, have better productivity. So think about the prevention, and also for our BroMatters research projects. I just mentioned that we're going to organize the expert panel, and if for anyone who are interested in become involved in the panel, you are welcome. And so it's you don't have to feel that you're too committed, and you can it's totally voluntary, and so think about it. Thank you very much.
And thank you so much for your presentation.